Hello everyone, and thank you for joining. My name is Cheryl Fatabene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, Electronic Medical Records, Patient Care and Legal Implications for Nurse Practitioners, by Melanie Balestra, lawyer and nurse practitioner. Today's webinar will be available in the upcoming week on our Nurse Practitioner Support and Alignment portal page, and a link to the recording will be sent to all registrants. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation, especially since we have a large group today, so please get your questions in early. Use your questions tab on the GoToWebinar control panel as seen here to ask your questions, and they will be relayed to the presenter at the end of the webinar. A survey will pop up also at the end of the webinar and will be sent out in an email later today. Please take a few minutes to complete the survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane as seen here in your control panel. You can click on the name of the handout and it will download via your default browser. At this point, I'm going to turn it over to my colleague Joseph Reyes from the AANP to tell you about how you can receive your free CE credit.
Hello everyone, this is Joseph with the American Association of Nurse Practitioners. Today's webinar is accredited for continuing education credit. It will be accredited for 1 hour of CE. There are a couple of requirements in order to receive CE credit, the first and most important of which is that you need to attend at least 55 minutes of this presentation. So if you cut out at 45 minutes, you will not qualify. So try to do your best to attend at least 55 minutes. You will also be required to connect to the presentation slide deck. So what that means is phone in only participants, those who've only just called in to listen, will not qualify. So if you can find access to Wi-Fi or the internet and get connected to the presentation slide deck, that was the link that was sent to you upon registration. So click that link and connect to the slide deck so that you can hear a presenter and also view the presentation in real time. Once this presentation is over with, I'm going to go through the entire list of registrants who attended the presentation. I'm going to vet that list for those who attended at least 55 minutes. And then I'm going to send an email to everyone with very specific instructions in the email, of course. And there's also going to be a passcode required to access the CE credit on our AANP CE Center. If you have any questions in the meantime, you can direct them to me. My email is listed there as well. And hopefully, I'll be able to help you as soon as possible.
Thank you, Joseph. So I wanted to take a quick moment to talk to everyone today about the national investment taking place in quality improvement in the U.S. with the help of our federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI for short, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and enrollment of 150,000 plus providers across the country. The NNCC, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 76,000 members. CMS funded the NNCC and AANP to support enrollment of NPs into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material that facilitates practice transformation in advance of upcoming payment reform with CMS. The NNCC and AANP are the only nursing-focused grantee of the TCPI project. And NCC and AANP agree that the initiative is important to ensure NPs receive the support they need to remain competitive in a changing healthcare landscape. Nurse practitioners are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove it by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for value-based reimbursement. So how do NPs prepare for upcoming value-based reimbursement? We want to use the program to prepare clinicians across the country for payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Many of you have probably heard of MACRA. It's legislation that was passed to establish Medicare's Quality Payment Program, or the QPP. Under the Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments: MIPS, or Merit-Based Incentive Plans, and advanced APMs, or Advanced Alternative Payment Models. Most clinicians will end up associated with MIPS, or the Merit-Based Incentive Plans. MIPS involves 4 elements that clinicians need to demonstrate successfully to maximize their Medicare Part B payments, and these are in the areas of quality, resource use, identifying clinical practice or CQI activities, as well as the effective use of health IT. If you can demonstrate these 4 elements in your practice, you too can succeed in a value-based environment. So I'm going to turn the presentation over at this time to Melanie Balestra. And Melanie, I'll let you take it from here.
Thank you. Good morning or good afternoon to everyone, depending on where you are. Just a little bit about my background. I have been a pediatric nurse practitioner since 1978 and an attorney since 1993. I continue to practice as a pediatric nurse practitioner at the Laguna Beach Community Clinic in California, and I also have my own law offices. I do conference presentations on a national basis, webinars, and write articles for various MP journals. So that's a brief introduction about myself, and we'll continue now. The slide isn't going forward. There we go. Whoops. Okay. I'm going to try and go through quickly some of the first slides because they're basically history, and you can get the information from the slides. And there's also an article in the February issue of Journal of Nurse Practitioners on this that was written by me. Okay, so the incentives for health information technology was they wanted to save lives, they wanted to reduce costs, and they wanted to use computers to track patient records, manage care, improve health quality by reducing errors. They want to practice specific medical records, electronic medical records, first used to digitize. And I'm sure you probably realize the difference between EMR and EHR is that the EMR is internal within the facility and the EHR is external, so that means you can communicate from one facility to another, which is the ideal thing that they wanted. And it's more efficient, especially with e-prescribing. You can send directly to the pharmacy. Okay, the impact is that obviously we grew the healthcare by $800 billion. There was pure usability, time-consuming data entry, interference with face-to-face patient care, inefficient and less fulfilling work content, and the inability to exchange health information. And there was a degradation of clinical documentation. The roots, the 60s and 70s, academic medical centers developed the systems. In the 70s, the U.S. Department of Veteran Affairs became involved. 1991, the Institute of Medicine's analysis of paper health records, advocating for computer-based patient records. Revisions in 1997, and then in 1999, the Institute of Medicine published To Error is Human, Building a Safer Health System, stating information that technology would in fact help reduce medical errors. Later years, American Recovery and Reinvestment Act of 2009 allocated $19.2 billion to increase EHRs, and in 2011, the HITECH Act incentivized payments to eligible professional hospitals and critical access hospitals, participating in what we all know is meaningful use. And through meaningful use, they're able to quantify at the end of the month, you know, what you did and what you didn't do. And this was done to improve quality, safety, efficiency, reduce health disparities, engage patients and families so that, you know, they could get into their records from outside the facility, improve care coordination, population public health, maintain privacy and security of patient health information, which we know has been a problem since we have many professional hackers who do hacking both for just personal satisfaction and to also get money. In 2015, they did modifications in meaningful use stage 2, and if those who didn't not successfully demonstrate were subject to a 1% to 5% payment adjustment. So now we're I can't say it. Anyhow, we are incentivizing people then to do everything correctly. Okay, in 2016, CMS proposed a rule that would consolidate 3 currently disparate Medicare quality programs into merit-based incentive payment system, MIPS, which was mentioned previously, and this included meaningful use of EHRs. And this goes into effect over timeline from 2015 through 2021 and beyond. And again, these were established by MACRA and by CHIP. Okay, issues. Systems can be cumbersome to use. Unfortunately, because we are a competitive society, instead of them adopting one EHR for everybody to use, we have multiple systems, and some are more difficult than operate than others. And if you're an MP that is an independent contractor or that you work in several facilities, this can be a real problem because you have to learn all of them. Okay, patient care is impacted. Rigorous data entry requirement done, difficult to navigate user interfaces. So again, it can be difficult to put in all the information you want, and sometimes you don't know exactly where to put it. And some of the problems I've run into is I'll input data and it comes out with a diagnosis for a patient that I disagree with. So this can absolutely lead to a liability issue. So in those cases, you can talk to your tech expert, your medical director, or whoever is in charge of the EHRs and see if you can do something to change that or put your documentation in there someplace so that if anything ever does happen, you do have that documented. Medication safety, categories of prescribing, transcribing, dispensing, and administering can be disjointed, again, leading to EHR-associated medication errors. So you need to be very careful in this area too. Now, I run into a problem where I try to e-prescribe amoxicillin, and for whatever reason, our system does not let me do that. So instead of doing it, e-prescribing, I have to go in and click a written prescription and then give the prescription to the patient. So this is something you can run into. And again, if you're in a larger facility and you have a tech person, it's so much easier to work with. If you're in a smaller facility and basically, you know, someone has multiple jobs and one of them is tech, you may have more difficulty doing this. Eye contact is another thing, and I think we all realize we spend so much time clicking here and there that sometimes we lose the contact with the patient and the interest with the patient because you're either waiting for something to come up or, you know, looking for the right thing to click. So this does create a barrier to communication. So you need to really sit down at some point in time, give the face-to-face contact and discuss with the patient what is actually going on. And this can be more difficult if you versus a tablet or something like that where you can put that in front of you and you still can have eye-to-eye contact and go back and forth. Okay, it's difficult to use screen and font sizes sometimes. Autocorrect or autofill functions you may not agree with. Inadequate LED lighting, lack of handheld devices to barcode scan medications if you are giving the medication from the facility, inefficient and delayed access to laboratory results. Sometimes they don't come into the system as quickly as you need them, and you still have to go outside the system to get someone in the facility to get them. Lack of interoperability with other systems, and again, like I said, the system I work with works just within the facility. So if I have to get any kind of information from another facility, I have to wait for them to fax me the information. So that can take an undue amount of time, and sometimes the patients don't want to wait for it. The templates are designed for common procedures and consultations. So you can have inaccurate data entry because of this, because it may not have exactly what you want to put in there. And then, you know, everything comes up on the screen and there may be 50 procedures under the word that you plugged in there. So then you're trying to look through and find, you know, exactly what you want. And even with ICD-10, it's far more complicated and far more codes than any other system, and you still can't always find what you want to say. So that can prove to be a problem because you're looking something that relates to what you actually want to say. You have documentation procedures that may have not even been performed. Sometimes that plugs in. I have a problem with BMIs in children's, particularly athletes, where the BMI is high, but there is no, there's not a dietary problem. It's because they're an athlete and so they have more muscle, but yet it comes up every single time saying, you know, that this child has risk or is obese. And so I have, the only way I can get around it, because I have not been able to change it technologically, is to just explain it within the system in documentation, explaining that this child is an athlete and this is the reason the BMI is high, that they actually don't have an obesity problem. And the distance recording of data from the visit with the patient. And this can be a problem also. Okay, clinical decision making based on real-time information. Other patient care issues can arise when there's no access, partial access, or incomplete access to medical data. So this is what happens too. Sometimes you have a system and something is offline and there's no backup available, or you have a combination, and we still do a patient and not patient, but paper and EHR, so that I don't always have the whole picture of the patient. I don't know what went on before, so you're doing your best to get a history from the patient to see what's currently going on and what happened in the past. And again, then that can take a longer period of time to get that information, since you don't have it readily available. But sometimes it's just not an option. And I know that large institutions are now having backup generators and all kinds of backup mechanisms, so that if something happens and the computer system goes down, you're not left without any information about the patient. Okay, patient privacy and security risks. Breach of confidentiality is elevated with an EMR or EHR. Therefore, you must be vigilant in preventing unauthorized access to patient information. And I know there has been problems. Some facilities will allow, like if you have student MPs, they will give the student MP their own access code. Other facilities do not allow that. And so, excuse me, you need to make sure that whoever is getting into the system has their own code and is authorized to get into the system. And this is where you get internal threats from poor password management. Again, most systems, I think our system, about every 3 or 4 months, you have to come up with a new password, which can be very frustrating because we have to have a password for just about anything anymore. And so you need to keep track of what your current password is. Disgruntled or disloyal coworkers. You do not ever want to leave a chart open, because if you do, somebody can go in there and chart on that patient. And it sounds ridiculous, but there are people that, you know, are angry with you for whatever reason, and they can go in and sabotage a medical record. So you absolutely need to be sure when you go out of that room, you either sign out, or if you have like a tablet with you, that makes it a little bit easier. But then if you have a tablet that you carry around, you also need to make sure that you have it on you at all times, or if it is not on you, then you need to make sure that you have signed out on the record. And now it's becoming more available for MPs to get on the records out of the facility. So you need to make sure that the laptop or whatever you're using is HIPAA compliant, and again, that it is protected outside the facility, so there's no chance of anybody getting into that laptop and charting or writing anything about a patient. Again, transparent physical security measures. You need to make sure that your security measures are up at all times. External threats. Again, hackers are just becoming more and more proficient. As you've seen, they've gotten into huge facilities like UCLA and I think some other hospitals in Los Angeles and throughout the world. So we need to become more and more, you know, aware that this can happen. External threats, again, now, you know, what they're doing is they're threatening they want $1 million, they want $500,000 to give you back all the records, or they will just totally destroy everything. Theft of electronic devices containing health information. So this is extremely important also, that you know where your electronic devices are, that they are protected. And let me tell you, please, please, please don't use texting for information about patients. Texting is discoverable and very easy to hack into. So you're using an EHR, make sure that you have it on some kind of protected device and that you're not texting the information about a patient from one person to another. And I know that texting is used, and it should absolutely not be used. Okay, HIPAA provides data privacy and security provisions for safeguarding medical information and requirement in the HIPAA security rule. This is embedded in Medicare and Medicaid electronic health records incentive program through meaningful use requirements. Violations and or lack of privacy when using an EHR system could result in HIPAA violations. So again, you need to make sure that whatever device you're using is HIPAA protected. And with the use of telemedicine is another, or telehealth is a popular issue right now also. You cannot use telehealth on a non-protected system. So if you're going to be doing telehealth, because I know people are using FaceTime, you cannot do that. It's not protected, and you easily, something could happen and you would be held liable for this in the future. So when you're looking at EHRs, just remember that an EHR is a protected system, and that texting and FaceTime and all of that is not protected. Liability and ethical problems. There's widespread use of EMRs and EHRs contributes to more errors and malpractice liability. And this is something I am predicting that we are going to see more and more in the future. This copying and pasting notes, cloning, is just horrendous to use. You see this used more in large facilities such as, you know, hospitals and that kind of thing. And you go dizzy when you're the person having to review those records, because it's like you can get 500 pages or more, and it's like reading the same thing over and over again. So where when we used paper records, we would just, go right to the problem and list it so it was easier. In all actuality, if you put aside the handwriting issue, they were easier to read in many instances because it was more of a focus thing. Where electronic health records, we have, again, all these clicking, and sometimes you can review 3 patient records who have the same problem and they look exactly the same. So you're not seeing the individuality of each person. And so that is going to cause problems, liability issues in the long run when you're not writing it. And I mean, just Monday, there was a student in the clinic, and we were having, problems, just in teaching and saying, you really need to individualize the patient, and specifically to this patient, because otherwise it's just going to look like any other patient. Okay, so data could be outdated or inaccurate, and this happens again. The systems have to be constantly checked to see if you're, updating the information, and when changes are made through the system, through different disease processes, all of these kinds of things, we rely on them to completely update everything. So if something isn't updated and you see that it isn't so, you need to document what you're actually seeing and finding. Vital signs that can never change or repeated information can be used by the plaintiff's attorney. And that's what they look for. They just look at that and they say, look, every time this patient comes in with this problem, it looks like exactly the same thing every time. So what is the MP doing? What different is happening with that patient? Because it just looks like, it's the same every time. So, they're not really doing anything for the patient or assessing the patient thoroughly. And the other thing that I stressed on Monday to the student too is that we tend to, just put something in a system is negative, and even in the EHRs, it can just list certain things. But you need to make sure that what you're doing, if a patient comes in with a certain complaint, that you're doing assessment according to that complaint, and that you write down that you checked for this, you checked the Babinski, or you checked this sign, or you checked this, and this was negative. Because the first thing they'll do when you go into court is they'll say, oh, well, they didn't look at any of this because it just says negative. So what does that mean? Did they check this? Did they check this? Did they check that? And it's not written. So it's the old adage that not written, not done. And I mean, you can argue that your standard of practice is to do all these things. But believe me, when you're trying to defend somebody, I love every MP that documents well, because it makes my job so much easier, and it's so much easier to get a positive outcome for the nurse practitioner. Use of templates. Narrowing scope, or do not allow entry of data or impressions suggesting alternative diagnoses can expose the user to legal liability. So again, you need to put specifics and not just look at that template that was entered there. You need to be very specific about that patient. Ignoring clinical decision support. Continuous alerts. So if there's time limited and something happens to the patient, the MP is at risk. So you need to put an alert if there's something specific going on with that patient that needs to be assessed the next time that patient comes in, that there should be alert on that. And also there should be some kind of alert to go out when patients don't come in. Because a lot of times you see that the patient had appointments that were they didn't show, they were called. All this needs to be documented. Now, this may not be your area documentation, but you need to make sure the front that this is being done, because again, if a case comes up and you have nothing showing you never followed up on this patient, you can be held liable. Okay, late entries and changes, and this is something that they love. It's a challenge to capture all pertinent information in the EMR in real time. Amendments and changes is a double-edged sword. and I'll tell you why. It's the Board of Nursing, and also, you know, in malpractice, they see that if you write an amendment that, you know, oh, they forgot to do something, so they're covering themselves by doing this. But on the other hand, too, I don't know how many of you have this happen, but that I'll be, you know, I think I've gone through everything, and I'll be walking at the door, and the patient says, oh, I forgot to tell you that Johnny's been complaining about blah, 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 blah. So you're back in the door and trying to figure out, you know, what's going on with Johnny. And so in this case, you are going to have to write an amendment. And I would, you know, then put an explanation. Patient had been assessed, you know, and questioned, and, you know, the mother decided or realized that the patient had another problem, and so mentioned this. And so then you document that. And that's usually within a short period of time. The longer you wait to write an amendment, the worse it can be. So those of you that, you know, don't finish your EHRs, you're going to finish them at the end of the day, that is not really a great idea. And I know a lot of MPs do that. But when you're reviewing these EHRs, you look at the time entry, you know, of the patient and when it was actually charted. And the first question that comes to mind, why is there such a discrepancy? You know, this was done at 9 o'clock and the charting's at 5 o'clock. You know, what's going on? So this, again, puts you at risk for liability. And what you can do, and I know because some of you have huge patient loads, and you need to talk about this to your facility, to your employer, because the only person that cares about your license is you. And I can't tell you how many MPs are taken advantage of because their employer says, well, you can do this, well, you can do that. Well, you can't. And so there needs to be some kind of time element for the MP to be able to finish all of the charting and to be able to chart on time. Because the longer, I mean, you just automatically look at that when you're, you know, defending an MP to see how late her entry is. And the first thing they do is say, oh, you know, they screwed up, so this is what they're doing. They're CYA. Okay, failure to document or incomplete, inaccurate documentation. Again, documentation can either make or break you in a case. This leads to patient injury and malpractice litigation or licensing issues from the Board of Nursing. And I must say, this does happen because I have gotten reports from a patient that was seen in the ER over the weekend. Monday is always busy because of that. And I mean, one was just absolutely ridiculous because it was on a 7-year-old male patient and had my patient's name on it, who was a 9-year-old little girl. So I don't know how thorough that was in the ER, and it was signed off by the doctor. We use scribes a lot, or not me personally, but in the ER and in a lot of hospitals, they do use scribes. So if you're using a scribe, you need to make sure they're putting the right information down. I mean, if this would have ended up in a lawsuit, I mean, the ER would have been, the MP there would have been just totally held liable for this. So you need to make sure that the charting is accurate. And again, I realize that time elements can be an issue, and but you've got to find some kind of solution. And this ranges from failure to transfer all information from the paper chart to the EHR. You fail to sign the EHR notes. You're checking boxes indicating services were performed without providing supporting documentation. And I know I've gotten I get calls from MPs that say the physician wants to sign all the charts because that way then they have to pay for one less MP or provider to sign up for the system. And that's an absolute no-no. You just don't do that because, you know, again, the doctor's going to be liable, but you're also going to be liable. I mean, it borders line on fraud for billing purposes. So you just don't want to do this. I mean, it's not up to you to save the person money. Autofill functions can inaccurately complete fields, drop down incomplete, or limit ability to chart information. So again, you get so used to clicking everything that you can sometimes click the wrong thing or the drop down doesn't come down correctly. So really be aware of this, and it's a good thing, you know, if you have periodic meetings where they have updates on your EHR and you can discuss problems that you're having with it. And these are tips for navigating. Complete a basic training. Make sure you have a training on the EHR. It's, as I said, more difficult if you're an independent contractor and you're going with multiple facilities. Request written basics for the use of the system. Have a cheat sheet. You may need to know how to order lab tests, submit e-prescriptions, order referrals. I have a heck of a time ordering referrals half the time because our EHR, sometimes it wants to say like refer to ortho, and then that doesn't come up, so then I put ortho in, and then it will come up with refer. So again, these are things that hopefully can be corrected, but it depends again on who is assisting you with your system. And ordering, like I mentioned, ordering referrals. Advocate for regular staff meetings. And at these staff meetings, you can discuss potential solutions. You can access information technology staff for help. Based on patient workload, work ahead if possible. If you know that some patients are coming in, and then you can enter information. We cannot do this on our system, and we have a variable no-show rate, so that really prevents you from doing anything. Like I said, ask for administrative time to complete data entry. Explain the electronic documentation procedures to patients, letting them know they can interrupt or with questions or additional information, because you get so involved clicking and typing that the patient basically feels left out. So you want to make this patient included. Talk with the patients before entering information into the EHR. Try to get their eye contact. Try to discuss everything with them. And alternate between documentation and conversations, that you're going up and down. And I know with children too, I sometimes will put them on a seat and let them watch me do it. Some are more interested in others. And because sometimes children can get very bored. So I try to include them also in doing this, and they sometimes get fascinated. Read back information as you type it into the system, because sometimes it'll make the patient feel more secure, and you want to go over it to make sure that you have not missed anything and that everything about the patient is included. Work with practice management to design or arrange examination rooms to facilitate communication with patient. The exam room I work in is very small, and our computer is huge. I mean, it's bigger than the one that I have on my office desk. So just moving that around can be really difficult, and trying to get, you know, and have a personal interaction with the patient. So this is something in planning that if you can do things so it's easier to interact with the patient. And like I said, the tablet is great. Do not rush when entering data, and review before you finalize it. And I know you sometimes get in a hurry and you want to get from one patient to another, but it's just so easy to leave something out or to miss something. And I mean, just even looking at the patient name, age, and sex, the diagnosis, the current medications and new prescriptions, and you need to go through and make sure that you click reviewed, because even that you reviewed it and you didn't click it, then when it comes up in a quality assurance kind of thing, it shows you're not reviewing medications with patients. So these are the kinds of things we didn't have to remember before, but now we have to remember that there's certain boxes that always have to be clicked. Lab or radiology test ordered, and follow-up appointments. And this is extremely important too, and to know what kind of a follow-up appointment is for, and then whether the patient has accepted that he wants to be able to communicate, through the internet with the facility and the provider. Avoid jargon, obviously. Review information before finalizing the entry. Again, this is important to make sure that you have everything in there that you want to be in there. Do not rely on systems that either warn or will not allow impossible information, such as hysterectomy code for male. And again, you have to realize that this is a computer and not a person, and the computer is not seeing the patient. You are the one seeing the patient. So you are going to have disagreements, and sometimes it's frustrating because you can't get anybody to help you to change it right then and there. So again, document in there what you're actually seeing or doing, and you may have to go afterwards to say, this is wrong with the system, or it's not doing something. And it can work well one day, and the next day you go in and it's not working well. So these happen, and you just have to, again, document. And each patient encounter should be recorded as a standalone record. So you need to have everything in there that's applicable to that visit. You can't rely on always going back because you may not always be able to. As I said, avoid cut and paste and cloning to save time. And templates may not exist for the specific problem or visit type. So structure of note does not fit clinically or reflect patient's condition and services. So you're going to have to comprise your own note. So this is important. Atypical patients may have multiple problems or extensive interventions that must be documented in detail. And therefore, it is up to you to do it and not just keep on clicking. Have the ICD-10 codebooks available for reference in the case. Templates or drop-down boxes are narrow in focus and do not provide appropriate diagnostic information all the time. So just again, remember, this is a computer that only has certain things inputted. So you can absolutely have the computer making a mistake. Create a cheat sheet or coding cards for common codes you use, and we all have common codes that we use. But again, and this goes into billing, make sure that the documentation supports the billing codes. And again, you do not want to have somebody changing your billing codes, which happens. I've run into several cases where the MP has called me and said that, they keep changing her billing codes to up, the income. And I told her she needs to inform them. If they continue to do that, she needs to get out of the practice and report them, because that is absolute fraud. Okay, avoiding malpractice errors. Request checkboxes associated with those amounts be placed further apart on drug ordering screen so that it's easier to facilitate. And sometimes the dose amounts come up, and for kids, and they're not right. So I have to go in and change the dose amounts per that particular child. Have a pop-up box that confirms the ordered medications before closing up the record, and work with practice administration to institute procedures that routinely update and reconcile medication lists. Establish processes for logging all activity, for addendums, corrections, retractions, deletions, definitions for period of time for unlocking and locking the EHR, amendments, clarifications, additions are normal part of the record, CMS guidelines, federal, state, and local laws. Don't depend on someone else to correct your mistake. Confirm that the record has been appropriately corrected if you do make an error. And that does happen sometimes, especially if you get a family in of like 4 or 5 kids and you're seeing all of them. I mean, sometimes it's a dizzying effect. So you need to make sure that everything is entered correctly. Check for duplication and conflicts. There's a phenomenon known as prompt fatigue, which can lead to the lack or misuse by providers entering information, and you know what that feels like when you've seen quite a few patients, 20 patients, 30 patients in a day. So you need to really keep up on this. Define a policy with administration if using EHRs and paper charts, because you need to make sure that you're getting all the paper information. Do not share your password and change it frequently. And know your confidentiality policy. Ensure you are fully trained on policies, procedures, system functions, and capabilities to prevent system fraud. Know your security and integrity requirements. Know what constitutes violation of your EHR policy procedure and the consequences of this. Carry your own malpractice disciplinary insurance. And I cannot stress this enough. I know the deep pocket is still, you know, one of the arguments. Well, if you have your own insurance, then we're going to, you know, we're going to sue you. So you're going to be gone after. This happens, but very occasionally. And here's the thing. If your employer has the insurance for you, then your employer has control over whether or not to settle the case, whatever to do with the cases. And I've had multiple cases where the MP has called me. The MP has done absolutely nothing wrong. However, the facility wants to settle the case. Her name is in the case, and even though they've done nothing, she's done nothing wrong, her name is still in the case. And they want to settle it because it's somebody else did something wrong, or they just don't want to spend the money on it. Okay, it gets settled. Anything, various states have amounts of, you know, anything above $3,000, anything above $5,000, excuse me, whatever the amount gets reported to the Board of Nurses. Most Board of Nurses look at a settlement as a guilty plea. So if you, you know, your employer says settle, you don't have any say in it. So you have to settle the case. The other thing is that many employers don't cover disciplinary insurance. So you get a patient that's mad at you, you get an RN or a staff member that's mad at you, they report you to the Board of Nursing. Your facility may not cover for that. So you're going to have to pay out of that. And if you have to go to hearing, you're looking at $25,000 to $50,000. So that's a lot of money. And when you're looking at insurance, one of the things you have to look at is who do they give you to represent you. One insurance company has an endorsement with the American Association of Nurse Attorneys, so that for any disciplinary matter, they'll tell you who, you know, you can call that has a nursing background, and many of them are NPs, so you can get someone that actually knows what they're doing. I had just recently people called me from different insurance companies, and one of them, it was a construction attorney that they gave her, and then another one said, no, we're going to pick whoever we want. You can't have whoever you want. And so you want an insurance company where you get to pick, you know, whoever you want to represent you in a disciplinary action, because you want somebody that knows about MPs. And and an attorney that represents physicians all the time does not necessarily understand what MPs can and cannot do, or their scope of practice. So my recommendation is to always have your own insurance. It also covers you 24/7, so that if you're at a party or something and somebody asks you a question and you give them a medical advice and then they get mad and they report you to the Board of Nursing, your employer is not going to cover you. So that, and there are the three main insurance companies are NSO, Cotterell, Pfeiffer, and Misher, and Continental Insurance or Medford Insurance. So you need to call the insurance companies to determine what they have to offer and ask them specific questions. If I get in trouble, who's going to represent me? So that, and I get very excited about that, enthusiastic about it, because I'm the one that handles the cases. And when I have an insurance company that allows, me to work with MPs the way I know should be represented, I get very happy and very excited. And it saves you a lot of money.
Melanie,
Okay.
this is Cheryl. In the interest
Okay.
of time, we have
Okay.
questions that are pouring in.
Okay.
So what I'd like to do at this point, because those on the call have the conclusion slides for you, I'd like to, with your permission, move forward to the Q&A portion of the program.
Sure.
So we're going to take back the cursor here, and for everyone on the call, all the references are listed here. Those conclusion slides are part of the handout, so you can go back and read through those. And there's some really great questions and feedback that we're getting from people. And we're going to just start going through these questions for you, since we only have about 10 minutes for questions.
Okay.
So I will turn it over to Tiffany at this point and have her read out the questions to you.
Thanks, Melanie. So the first question that comes from Barbara, and Barbara is asking, what are the implications for a provider that has to chart in a system that is not compatible with an EHR that is the primary system in a facility, like those that are when working in a specialty care facility?
Oh boy. That's unbelievable, because all the systems within the facility should be working, because what it's going to do, it's going to prevent you from probably getting necessary information from the primary care provider. What I would do is I would try and set up a meeting with the technology department within the entire facility, and maybe start a dialogue from all the specialty clinics and the primary care ones together to see how you can begin to let these systems interact, because it definitely puts you at a disadvantage, because you're not going to have all the patient information, and as an individual you can't do anything. But I would definitely get a dialogue going, within the facility, and just have someone discuss, and even have the facility attorney come in and talk about the liability issues, which are tremendous if you're not communicating with your own facilities. Does that answer it?
Great. Thank you so much. I appreciate that. The next question comes from Paula. Paula is asking, she wants to hear a little bit more about your perspective on web-based EHR systems and how to keep this HIPAA compliant.
Okay, the web-based systems, again, what you want is a software system that has the tools, that the technology built into it to make it HIPAA compliant. Because, what they put in are different kinds of coding systems and that kind of thing. I am not a technology person at all. And if that is within the system that you're using and within the software that you put in your laptop, that should protect you as much as possible. But that's what we're looking at now, is all the HIPAA, and there's multiple softwares out there that are HIPAA compliant that you can put. Now the problem is your laptop can be stolen, and there's nothing that can be done about that. But again, you would want a system that would either, say after trying to enter it, shut down after so many tries, or, again, whatever they do in technology. But you would want the system to absolutely, have a guaranteed HIPAA compliant.
Okay. The next question comes from Alyssa. Alyssa is asking for your recommendation on accessing an EHR while at home. Do you recommend using a workplace provided or employer provided laptop, or is using a personal laptop okay?
I prefer a work one if possible. If not, again, as long as they have put in the software into your laptop that is compliant and HIPAA compliant and interacts with their software. But if you were doing that, I would tend not to want to use that laptop, for personal, I would want to have a laptop that's kind of separate that you just use for the hospital, or not in the hospital, but whatever facility you have. Because the more you get into something, because you'll notice that at work, you know, you can't necessarily do that. So I would want to have a, you know, one that's primarily used for work.
Okay. There's a couple of questions that are coming in regarding obtaining malpractice insurance and what type of malpractice insurance. Specifically, do you recommend a malpractice insurance company, and what is a typical dollar amount?
Okay, I do recommend. Now, okay, I get paid various rates from the different malpractice companies, so that I don't have a financial interest in any of them. I don't get paid to lecture for them. You know, none of that. I have worked with Nurses Service Organization over the years, and I find them to be the best for MPs, and there's several reasons. They have what's called an advisory board, and on that board they have MPs and educators and RNs, and it's different than, I've been on drug boards and you know, and this advisory board, and this one truly looks at issues and problems that are arising for MPs. They allow you to choose whatever attorney you want if you have a disciplinary case. They charge, I believe their charges are more than some of the other insurance companies, but the problem that's arising, the current case I have, is that she paid a cheaper insurance company, and she's the one that got in a construction attorney, and now she's paying me out of her own pocket, so she's actually, you know, paying more than you would have to. So the NSO, I think, can run from anywhere from $600 or $800, I think, for family, and I think it is more for pediatrics, and can go up to $1,200, $1,500. But again, it's what you're paying for, because when the time comes and you need somebody, you really need somebody, and it is a tax write-off, so you can look at it that way. But they're the easiest to work, and like if you have a problem and you call them, they'll address it right away. A lot of the other insurance companies, they'll just say, well, have they filed a lawsuit? Have they filed anything against you? No. Well, we can't help you. So, and NSO doesn't do this. They'll say, okay, we'll get somebody to answer your questions and help you out right now. So I just found over the years that they are the easiest, and definitely represent MPs the best. And they were the first ones to represent us too.
All right, thanks for that recommendation. We think we've got time for maybe about one or two more questions. There's a couple of questions that are coming in regarding the use of personal cell phones or even FaceTime when communicating with patients. What are your thoughts on using these mediums when communicating with patients in terms of security and compliance?
No. FaceTime is if a patient, you're discussing a patient's problem, I mean, you're safer using a phone than FaceTime, because FaceTime can be hacked into by anybody. So I would not advise using FaceTime. And this is where we get into the telehealth issues and that kind of thing too. And that's why you want a protected system. If you're going to communicate with a patient, you should be communicating them through your you know, EHR telehealth system through the office or facility that you work for, and that's the way you should be communicating, or by phone. But I do not recommend using you know, FaceTime or texting or just regular email. You really should be doing it through the facility.
Thank you so much. There's a lot of great questions. Really appreciate all of your expertise. What the slide we have up now is for TCPI and our Nurse Practitioner Support and Alignment Network information. So there is my contact information, Cheryl Fatabene, as well as my colleague Tiffany Depew. If your questions have not been answered, or if you have additional questions, please feel free to send us an email. And for those questions that we did not get to today, we will forward those on to Melanie, and then she will respond, and then we'll forward them back to you. If you're interested in additional information about MACRA or upcoming payment reform, please go to the URL noted at the bottom of that slide there, and it tells you a little bit more about that, as well as basic information about MACRA and MIPS. And if you don't know whether or not your place of practice is going to be moving to value-based payment, you should be asking those questions at work. And as in the same token, I would also say that for all of you on the call, please feel empowered to, go to supervisors or others within your organizations if you have concerns about security or the way that things may be happening in your place of practice. It could be that no one else has asked the questions. As Melanie has pointed out, there's a lot of places we can get tripped up. So I hope this information has been helpful to everyone today, and I wanted to thank you all for joining. And just finally to let you know, we will be running another Lunch and Learn next week, and it will be myself and my colleague Tiffany Depew, and we'll be talking about enhanced communication in primary care settings for practice transformation. So please join that if you can. Melanie, again, thank you so much for your expertise. We will be ending the webinar at this time. Thank you all.